Hi there. My name is Gregory. I'm a professor at the University of Texas Medical Branch in Galveston, where I've recently moved from my affiliations with Duke University, Duke NUS School of Medicine, and Duke Kunshan University. Today, I've been asked to talk to you about emerging adenovirus threats and new interventions that are coming down the road. Much of what we know about adenovirus has occurred through epidemics. And we'll be talking a bit about those. First, some of my financial disclosures are shown here, but really there won't be anything that I've mentioned about these organizations. Well, adenoviruses are seen as sort of innocuous viruses. Here's a depiction of what the US CDC has shown, and they quip anyone can get infected, but most illnesses are not serious. While that's true, they don't emphasize that sometimes these are very serious and cause significant morbidity and mortality, and I'll be talking to you about that today. First, a little bit about the viruses. They were discovered in 1953 by Rowe et al. They're double-stranded DNA viruses. They have no envelope. There's some dispute about this, but classically, at least 56 unique serotypes have been identified, and we'll talk about new classifications soon. They're interesting in that they affect almost all human systems, respiratory, enteric, cutaneous, the conjunctiva, even encephalitis, and they have an affinity for receptors and many different organs. So pretty mixed bag of signs and symptoms they can present with. The illnesses, as I alluded to, often are mild among people who have good immune systems, but sometimes they can be severe, and particularly severe among those that are immunocompromised. Transmission comes through multiple ways. Classically, we think of it as ingestion, fecal oral, respiratory, large droplets, direct contact, venereal transmission, but now there's more evidence that even small particle aerosols can carry adenoviruses. Adenoviruses, I'm going to argue, have caused significant morbidity and outbreaks among crowded populations, especially healthy military trainees, institutionalized, sometimes schools, for small children and even colleges, and then places where there are a lot of immunocompromised people together, such as a transplant ward. Now, I mentioned earlier that 56 recognized serotypes. Well, we're moving away from the sort of a serotyping strategy that's been classic for many viruses to molecular typing strategies, and adenoviruses are included in this. And there's a debate going on right now with respect to how to classify these viruses. But currently, the presiding body is the International Committee on Taxonomy of Viruses, and they look at all adenoviruses, not just the human ones, as in 6 genera and 86 species in the latest meetings that they've had. The human genera is under mastid adenovirus, and there are 7 species now, A, B, C, D, E, and F, and G, that include what formerly were serotypes. And so you get something like this. We know that species B and C often cause endemic respiratory illness, and the known types, they're getting away from serotypes, the known types are 1, 2, 3, 5, 6, and 7. At any rate, it's still a bit opaque, and you have to sort of be able to work your way down to the typing strategy to talk about a specific virus group. And there are different ways to do the typing. Well, classically, the adenoviruses were found in military trainees in the 1950s in the United States. Actually, two groups detected them, non-filterable agents, and they've continued to cause epidemics in military trainees since then, not just in the United States, but in many places of the world. And one of the characteristics of the military trainees is that you basically bring these young, healthy men and women together, and they have a lot of stressors in their training. Their hygiene is not very good. They have, lots of environmental contamination, and there's, just a lot of close contact. So you can see here in this photograph from a U.S. Marine Corps training experience that they're breathing, exhaling into each other's inhale sphere of influence. And so really easy if you move viruses through a large aerosol or small aerosol to infect a whole cohort of these. And there have been really well performed studies to show that these people, even if they have some immune response, almost cannot escape infection with whatever virus is circulating in the camps. Well, this is one of those papers where they showed they followed 341 recruits, and the susceptibility was pretty high for adenovirus 4 at enrollment, and at closure, 97% had been infected in this rather short training period of 12 months. And the virus was essentially everywhere you look. So this is a pretty hardy virus, double-stranded DNA virus, and can last relatively long time in contrast to single-stranded RNA viruses. Well, there has been a long, interesting history. These viruses have plagued the US military, and there were quite a few outbreaks before they began to develop vaccine constructs. And you might know that in the 60s and 70s, these constructs were rather primitive. Now we're much more sophisticated. And there have been shifts, if you will, in the strains that are circulating in these camps. So you kind of need to do monitoring, and the vaccines greatly influence the endemicity of the strains that circulate in the camps. So if you introduce an adenovirus 4 and 7 vaccine, it can really change the ecology of the virus in the camps. Well, there's a long history of developing vaccines, and I'll just say that the best vaccines were developed in the 1970s at the NIH, and they were one of the few at the time enteric-coated vaccines. And so they grew out virus, and they put live viral material in tablets coated with a coat that would survive the gut acidity. And once it made its way down into the intestines, it was absorbed with, and interestingly enough, the immunity that resulted protected the respiratory tract, not just the gut. And so very interesting phenomenon. And now we're seeing that possibly employed against other pathogens, and that is oral adenovirus construct vaccines. But anyway, this approach was sort of a surprise, but it worked, and it's been used off and on since the 1970s. Well, there was an interesting event that shows the value of engaging the science media. The Department of Defense in the late 90s was challenged by the FDA that the companies making the adenovirus vaccine could not meet the new standards for production. They weren't safe enough. And the company went to the DoD and said, look, you're the only ones using the adenovirus 4 and 7 vaccines. We want $10 million to upgrade our manufacturing facility so we can meet the new federal requirements. Well, the DoD refused and said, well, adenovirus is no longer a problem. Long story short, it was no longer a problem because the vaccines work very well. And when the last stocks of the oral adenovirus 4 and 7 tablets were expended, then we saw huge outbreaks of adenovirus 4 and 7 in these recruit camps. And these were largely occurring among healthy people in the United States. And when two rather healthy young military trainees died, this made the headlines of the Wall Street Journal, very influential newspaper in the United States. And this article basically influenced the DoD to find a way to bring them back. And they did so at the lowest bidder, and it took about, it took more than 20 years, but they successfully brought the vaccines back, and they were used and remarkably effective, 100-fold decline in adenovirus disease burden, and thought to prevent some over 12 months, 1 death, up to 2,700 preventable hospitalizations, and up to 13,000 adenovirus febrile illnesses. So really worth giving this vaccine in military camps. Here you can see graphically the influenza the febrile respiratory illness rate, which was largely due to adenovirus. There's some other viruses in here, but you can see the separation between the adenovirus 4 and 7. And when they administered the vaccine again, boom, they knocked down this febrile illness rate. And so, combining adenovirus vaccines with seasonal influenza has done much to reduce respiratory virus military in the U.S. military camps, respiratory virus morbidity in U.S. camps. Well, we're not alone in seeing problems with adenovirus in the military. China has experienced big epidemics as well, and they've had other adenovirus types cause those epidemics. They share epidemics with 7 as we do, but they've also seen epidemics with type 3 and a type 55 that they have developed. And so here's a paper reporting their work with a recombinant trivalent adenovirus 3, 7, and 55 vaccine has seemed to work. Now, as far as I know, these are not routinely given yet, but I'm not quite sure, I have all the knowledge of what's going on. Well, in addition to respiratory epidemics with pneumonia and sometimes severe morbidity or even mortality, adenoviruses have been known to cause some unusual, or at least be associated with some unusual morbidity. Here you see some of that in their papers we reviewed in this 2006 report. Bronchopulmonary dysplasia, sudden infant death, chronic pulmonary disease, small bowel transplant problems, cardiomyopathy, obstructive airway disease, asthma, intussusception, and one of the most intriguing and still, I think, somewhat controversial is adenovirus infection associated with obesity. So this has made some cartoons that's kind of interesting. Wouldn't that be something if adenovirus was a big risk factor for obesity, and you could vaccinate against those strains and maybe reduce your risk of gaining weight and having all the consequences of that. Well, there's some interesting papers on this. It's a whole body of work. We don't have to get into it, but in particular, adenovirus type 36 was implicated and some others. And some people have coined the research area infectobesity as a viable thread of experiment and research. We've also seen a lot of antivirus transmission in bone marrow transplant and solid organ transplants with a number of different epidemics and high case fatality. And so often antiviruses are monitored in these transplants. And there have been some studies where the virus is thought to have come with the organ or the bone marrow, and some studies it's acquired in the community, and some studies nosocomially. But it's something to be dealt with, and in some settings, the internists that are supporting the transplant patients will modulate the immune suppressing pharmaceuticals just so adenovirus doesn't overwhelm the host's existing immune response. And so it's a little bit tricky. Again, you can have adenovirus illness that's community acquired, nosocomial, comes from the transplanted tissue, or that's reemerges due to latency in the host. There's evidence that the adenovirus can lie quiescent in tonsillar tissue and in other tissues in the body. And so if you suppress the immune system, it can start replicating again. Well, we were fortunate to be funded by the NIAID and conducting this U.S. Large scale surveillance for adenoviruses over a 25-month period. We did this in partnership with 22 medical facilities in 2004 to 2006. It was a big effort. And we basically got a bunch of adenoviruses, and they were from medical care facilities, big ones serving civilians and some serving the military. And our hope was basically to look for populations besides the military that would benefit from the 4 and 7 vaccines. And we didn't actually find that, but we found that other strains of adenovirus and subpopulations of civilians were increased risk. And they just include children less than 7, recent transplant patients, people suffering adenovirus 5 and 21. Now, not much has been done actively in surveillance since that time in the United States. There is some passive surveillance that the US CDC does. And from that passive surveillance, we've learned of subsequent epidemics. Here's an epidemic from one of the partners in that large paper. Marie Landry was at Yale. She says, I can't continue to collaborate with you because we're just getting hammered with the adenovirus cases, and I can't keep up collecting and filling out the specimens and filling out forms. And I said, well, do you think you might be having an outbreak? And she said, no, I don't know. And sure enough, when she looked at the data, it was a marked increase during the latter part of our surveillance. And further study, we found she had an unusual incursion with some rather low prevalence adenovirus 3 genotypes. Another adenovirus 7 genotype has caused problems in a number of areas, Chile, Uruguay, and Argentina being pretty well documented. It was thought to be more virulent in that caused larger, higher temperatures, longer hospitalizations. People affected required oxygen more often, and mortality. And there's a lot of secondary attack rates. So whenever a new strain emerges, sometimes it can lead to big outbreaks. Now, what in this strain might be associated genetically with severe morbidity? Well, we really don't know. But interestingly enough, here's another one, an Antivirus 7D2, detected in different parts of the world over time. Again, thought to be pretty virulent. So new strains can cause epidemics, and especially if they get into immunocompromised patients. Here's one, Adenovirus 7B, 84% attack rates, 50 residents, 27 hospitalizations and deaths. So when they get these immunocompromised, it can really wreak havoc and cause a lot of serious illness. Well, we had an interesting experience that suggests to me that adenoviruses have the potential to cause large-scale epidemics, if not pandemics. This is a report in MMWR where a adenovirus serotype 14, a rather rare, but not previously, but previously recognized old strain, suddenly emerged and was causing all sorts of very serious illness in multiple states and in the military. And we really didn't have anything, a vaccine construct or any antiviral to prevent this. First identified in the 1950s, but not very high in any of the surveillance studies until 2005, and suddenly 4 locations bust out with this and associated with severe pneumonia and death. So there's quite a bit of literature on this now, and places where people have found it, including in China. So these viruses move quickly, like influenza, like SARS-CoV-2. They're hard to control. And again, I would emphasize there's pandemic potential here if we get one for which people don't have a lot of immune protection. In other places in Asia and China, we've seen, as I mentioned, they've had problems with serotype 3 or type 3, as well as 7 and 55. We've seen some problems with 11 there, and China also. People are looking at influenza and SARS-CoV-2, and adenovirus sneaks in and causes an epidemic. And then some interesting reports that emphasize that this is probably born in small air particles that can be sustained in the air for some time. This is a report of a mixed airborne adenovirus and mycoplasma epidemic in a hospital. Well, I know many of you that are attending this meeting are coming from Singapore, and as I was invited when I was part of Duke NUS Medical School. So let me just tell you that you've had a number of serious outbreaks with adenovirus infection in recent years. Here's a paper from 2015 talking about the adenovirus outbreaks, 85 patients, serious illness. It had 7 adenovirus 7 and adenovirus 3. Another paper talking about dual pathogens. In other words, adenovirus and another virus causing mixed infections and more severe disease. And so, I think, and 2 more papers of adenovirus 11 and 7 in Singapore. This just reminds me to tell you that adenovirus can run with other respiratory pathogens. And so finding just one pathogen, you may have not found all the causes of the morbidity that you're looking at. This is a paper that Kristen Coleman, who until recently worked at Duke NUS with me, wrote in 2020, saying, well, there's enough adenovirus documentation that maybe Singapore should be looking at adapting new antivirals and vaccines, maybe making their own vaccine if they can't get the one made in the United States. And she had some pretty good evidence for this in this nice review. This was followed more recently with a review international of adenovirus 4 activity. And again, she found that Singapore had significant deaths associated with this strain. So we have posited that maybe adenovirus 4 and 7 vaccines should be sought for by Singaporean officials and possibly given to the military or maybe to certain high-risk populations who are non-military. Well, what kind of therapy, what kind of vaccines are available? Well, in the US, no approved antivirals are on the package inserts for, or no antivirals have, antivirus is an indication on the package inserts, so there's no FDA approved therapies. There is experimental evidence that a number of antivirals would work, and so people have been giving this off-label in various studies. There's some success with cidofovir and ribavirin and other antivirals, but not as good as we would like to see. And sometimes there's comorbidity like renal failure associated with that. But the most positive thing is a antiviral that is a analog to another antiviral that has some success against DNA viruses, cidofovir. And this basically was initially coined CMX001. And you can give this orally in contrast to, IV sort of medication. So it's attractive and it doesn't destroy kidney tissue. So there's some hope that this would be used in humans. It's looked pretty good in various different animal models, and also been used in small series in immunocompromised people suffering with severe adenovirus infection. So this may be the great hope, if you will, for future severe adenovirus disease. And I'll just say that these data are now, a bit old, and I'm sure there's much more in the literature where this has been examined further. Now, this product, which later was coined brincidofovir, is now got a new name, and the Chimerix, the company, has called it Tembexa, the commercial name, and recently it was formally approved by the FDA for treatments of patients, adults and pediatrics, with another DNA virus infection, smallpox. Well, how many people get smallpox today? Very, very few, and so there's not a lot of market there. So you can bet that the company is looking for other opportunities to use this safely against other DNA viruses, and there are several more that they probably are considering. I'm not privy to what their strategies are, but one day it would be nice to know that this brincidofovir might be available for patients suffering and very serious illness due to adenovirus infection. Well, another interesting phenomenon is the evidence that these adenoviruses may spill over between species. And here are some of the elements of that logic. Adenovirus 4 and 52 strains are very similar to simian adenovirus strains. So where in the virological evolution do they cross species? We don't know, but it suggests that that can happen. And then recent emergence of a non-human primate adenovirus outbreak was associated with human transmission. A outbreak in birds in a bird facility was also, it was co-infection with chlamydia, but also moved to the bird caretakers. And there's been some suggestion of a dolphin to human adenovirus transmission by some of the marine mammal caretakers for the US government. But even so, some experts in the Adenovirus world have said, nah, probably not. Probably adenoviruses are not going to cross those species. And don't worry too much because these events are usually one-off. You know, they may occur, there may be some secondary transmission, but it's not a big threat, not like coronaviruses. Well, I don't know. I'm not so sure. I would agree with that now. That paper's a little old, but there are, you know, here are the papers I mentioned earlier: non-human primate transmission to humans, bird transmission. So we have reviewed the literature as well, and it seems that the adenoviruses are very permissive with respect to other non-human cell lines, such as, I believe this is a porcine cell line. You know, so, you know, there are receptors in animals for human adenoviruses, and there are probably receptors in humans for animal adenoviruses. And because we can't see the animal adenoviruses with our routine healthcare diagnostics, we're probably missing them all the time. So we did this review published in Emerging Microbes and Infections, and I'll just say that we documented quite a few with, you know, very sparse surveillance, species crossings between the adenoviruses. Now, most of these were sort of non-human spillovers, but it just shows you that there's opportunity here. And, you know, I think we need to be monitoring for these, just like we monitor now for influenza spilling over to humans and coronaviruses. We need to be thinking about adenoviruses, because if you don't have immunity and you don't have good antivirals and the vaccines are not targeted against it, you're sort of in the same boat as we were when SARS-CoV-2 broke out. You know, uncontrolled transmission if the transmission is highly efficient. So this is our model. You can read about it, but basically we think that the adenoviruses are one of the 5 viral families we need to keep a pulse on. And the best way to do that is to look at people with intense exposure to animals, and almost all the animals have their own adenoviruses, to see which adenoviruses are beginning to insult human immune systems. And we can do that by, for instance, working with, you know, industrialized agriculture, doing monitors for adenoviruses in the people and in their animals. And when we see the same type beginning to take hold with immune responses in the animal workers, we can say, hey, that particular adenovirus from a cow or from poultry or from a pig is beginning to take a foothold in humans. Now, our position here is that it's one thing for one person to be infected, and it's probably a rare thing with an animal adenovirus. But if that virus is sustained in the animal population, it'll be affecting more than one person, and over time, it may mutate enough or recombine enough to become limited in transmission in humans. And then over time, it may become more efficient in adapting to humans. So the bottom line is that this is probably an incremental process. And if we conduct surveillance, we have time to see viruses that are really beginning to take hold. And we strongly urge folks to think about this instead of waiting till a highly efficient virus is detected as an explanation for an epidemic. By then, it's too late, such as we saw with SARS-CoV-2, and we're in a response mode. But if we can find it as it's adapting and mitigate it then we don't face these huge pandemics. So we have developed with collaborators in the veterinary world algorithms for looking at these 5 different viral families, one of which is the Adenovirus. And these algorithms involve real-time assays along with conventional assays to look and see what viruses are circulating in both animal and human hosts. Anyway, this is detailed in 39 pages with standard operating procedures for the laboratorians in this review article that came out this year in Viruses with me as the first author. So if you're interested in this, we've spelled it all out for you, and we're teaching our collaborators to do this kind of work. Well, when you do this sort of surveillance, what do you find? Well, we have found evidence that these viruses are spilling over. A recent vampire bat adenovirus in humans, where there are no vampire bats, interestingly, and a feline adenovirus in humans. And so these strategies work. Well, let me just sort of conclude here by saying that adenoviruses cause serious respiratory morbidity sometimes. They can periodically emerge to cause epidemics. They have potential to cross species, and we have potential to be infected with animal adenoviruses. And unless you have the tools, you won't pick those up. So you need to adapt special tools to look for animal adenoviruses in healthcare settings. And we really need better vaccine and antiviral therapy against these infections, lest we be caught totally unprepared like we were with SARS-CoV-2. Well, thank you so much for your attention, and I wish you well.